So, welcome to our info session on making your voice heard. Before we get started, in the spirit of reconciliation, Belongside Families would like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to their elders past, present, and extend that respect to all Aboriginal and Torres Strait Islander peoples of today. My name is Kelly, and I am joining you today from the land of the Darug people, and you're welcome to share the name of the country you're from in the chat. Today, we will hear from two very seasoned and special members of our Belongside Families team, parents Nerida and Pam. Nerida is a mum of 17-year-old Madison and a passionate advocate for rare diseases, disability, and inclusion. She proudly shares her voice through media and conversations with decision makers at all levels of government, with several charitable organisations, her local council, and the Children's Hospital. Welcome, Nerida.
Thanks, Kelly. Thanks, everyone. Hi, Pam.
And Pam is a mum of four, and she is very seasoned in this medical webinar space, usually is our facilitator. And she is a mum to four children, including Christopher, who was born with CMV and has complex medical needs. She treasures the everyday moments of family life and is devoted to walking alongside other parents with empathy, strength, and care. Welcome, Pam.
Thank you.
And welcome, everyone, and thank you for joining us today. Our panel today is all about sharing insights from parents who know what it's like to navigate the hospital system with a child who has a disability, high medical needs, and rare conditions. We'll start our session today talking about emergency visits, looking at what can make those quite stressful situations a little easier and how parents can advocate when it feels like they're starting from scratch. Then we'll move into planned admissions and surgeries, covering preparation, anesthetics, recovery, and managing equipment needs. Finally, we'll finish with the advocacy confidence, hearing how instincts have guided Pam and Nerida and the ways a parent's voice can really shape a child's care and recovery. So, because this will be a conversational style panel, Pam and Nerida, please feel free to add to each other's reflections as we go. Let's begin. So let's start with that unplanned admission, that trip to emergency. It can often give us that really horrible feeling in our stomach when we know that that's where our day is headed. And so, Pam, I'll start with you. When families arrive at emergency, it can sometimes feel like they're starting from scratch. What are some of the ways that parents can make that process a little bit easier?
I think it's really important to keep in the back of your mind the moment you walk in that not everyone knows your kid and you are going to have to repeat yourself a lot, but ultimately you're all looking for the same end goal of being able to try and help. So it can be really difficult and really frustrating to have to repeat yourself over and over again, but sometimes that's necessary. One of the tips that I've found that's really helped us with our emergency admissions and things like that is when we arrive at emergency, I don't actually tell them why I'm there. I tell them some of his diagnoses and complexities first. Because they're actually more likely to listen. So particularly when he was younger, I'd rock up to emergency with a 4-year-old who had a slightly mild fever and had vomited twice. And any other normal scenario, emergency triage would send you home, give them some Panadol, some water, a hydrolyte ice block, try and get some sleep. But obviously, Christopher's complex medical needs, he needs to be hydrated, he needs to maintain lots of different medications. There's a whole bunch of different reasons why he might be running a low-grade fever and vomiting. So I would always start with, this is his history, and then this is why we're here, and this is why I'm concerned. And that usually got me a little bit more traction than just launching straight in with, hey, my 4-year-old has a low fever and has vomited twice. So yeah, just like, and being mindful that sometimes it's not the individual that's trying to be difficult. They're just doing the best they can within the system that's not necessarily designed with our kids in mind. Yeah.
No, that's so important to remember. And it is that case of you have to sort of educate this new person that you've come across and give them the lowdown of who your child is and what their needs are. Nerida, do you have anything to add to that?
Yeah, I was just going to say, unless you're a frequent flyer of emergency and the same people you end up seeing in emergency, just be mindful of the fact they don't know you, they don't know your child, and they are just going off their learned experiences of what could be the case. And I think it's really important what Pam just said because, they could come to a conclusion about our children that's actually not relevant, but that's based on the fact that they don't know our kids inside out like we do. And I guess just, the whole theme of today's conversation is really about empowering parents to have the confidence to talk to the medical professionals about your child and recognizing that, you're not being disrespectful to them by voicing your opinion or your concerns that may be different to what they are suggesting. So I guess I'd really just start with that. We're a little bit different to Pam because my daughter has a blood disease, and so we have a temperature protocol. So we end up in emergency because of a temp, and there is a protocol that has to be followed as soon as we land in emergency. So for us, it's just it. This is what has to happen, and then they're trying to work out what is causing the fever. So we get triage straight away. She has to have bloods taken straight away. She has to start being pumped with antibiotics straight away. So, and then we can start having conversations about all the other things that, has to happen in emergency, which we'll cover off during today's session. So,
It certainly sounds like being that confident parent and being sure of yourself in a way that's what's helping the advocacy in this situation, especially when it can be high stress. And you need to make those doctors listen in that point of time because time can be critical. I know, Nerida, we've spoken before about IV access and how it can be tricky. What are some of the approaches that families might try, such as I think ultrasounds and or other specific techniques that can be used?
yeah, so following on from the fact that, you might not have ever seen the nurses or the doctors that are on the shift in emergency at this particular time, so they may not know. My daughter has hard access, and so as Kelly said, she's 17, so we've done this quite a few times. And once upon a time, I would let them have a go. I would let them try and find a vein. And sometimes that was so traumatic because they'd be digging around in her arm, in her legs, they'd have multiple attempts. Now I'm confident enough to say, okay, we're not doing any manual attempts. It has to be done via an ultrasound because she has hard access. And a lot of people, get offered, EMLA. And a lot of people don't know that EMLA will constrict the veins. So if your child has very thin veins or small veins like my daughter has, putting EMLA on is actually going to make it worse. But nobody actually tells you that until you start asking serious questions. So I just say, I'm really sorry. My daughter has really bad access. And I would just prefer if we use an ultrasound straight up. And some will say, "Oh, can I have a look?" Yes, you can have a look. That's fine. But I just say we have done this so many times, and this is what works best for my child. I appreciate that we've got to get a cannula into her ASAP, and you've got to take bloods, and then you've got to start pumping her with antibiotics. So this is the best route and the easiest route and the less traumatic for all of us. So yeah, I just talk about experience.
And I can't tell you how valuable that information is. Some people wouldn't know this about me, but I have a 20-year-old daughter who actually has quite a rare autoimmune condition. And when she has a flare up, the only way to help that is to have intravenous prednisone for 3 days. And it's but because it took them so long to diagnose her, her veins are shot. It's so hard to get access. And the last time they tried to do an infusion was at hospital in the home, and the nurses eventually just said, "We can't do this. We have to send you to hospital to get the cannula." So, I do wish I'd had that valuable information that you've just shared, Nerida, because it would have been so helpful to know that back when we were in our early days and those constant cannulas and blood draws.
Because
Um,
it's also stressful on the nurses and the doctors
yeah.
because, yes, this is their job and yes, they're experienced at doing this. But when you've got parents looking over your shoulder as they are trying to get a cannula in, you've got a child that's probably upset because they're sick, and
Mhm.
because you're digging around in their arm. It's a stressful environment for everybody. And so I'm trying to reduce the stress, just not for my child and my family, but also for the hospital.
Mm.
So, yeah.
Yeah, so important. Pam, I'm going to hand over to you now. Now, sometimes staff don't recognise a child's usual baseline or their needs straight away. What can parents do in those situations?
So, this actually happens to us quite a lot. Christopher is non-verbal and non-mobile, and he's completely tube-fed. So people who've never met him before have no idea that he's one of the most engaged and social people you will ever come across. People are his favorite toy, always have been. They will always be well better than anything we can purchase from a store to entertain him with. Um, and so for us, if he's not reacting when someone comes into his cubicle or his hospital room, that's really concerning because he likes making new friends and he likes engaging with those that are around him. Um, the him being really lethargic and unengaged is really, really out of character for him. So constantly reiterating like what my concerns are, um, and him being lethargic is a genuine concern. Like kids shouldn't be disengaged like that. They shouldn't be all slumpy and just tired and wanting to sleep all the time. That's not normal behavior. So, just constantly reiterating that that is another concern of ours. And um, I always talk about who he is and what his personality is when he's well. Like, oh, I wish you could see him smile, and I wish you got to see him when on his best day when he's really, really cheeky, or you should see him when he's playing with his siblings, and really setting the stage and like giving them a really clear picture of who he is when he's well, so that they really truly understand the level of my concern and that this is really, really out of character for him. I also have recent videos often on hand as well. So I can say this was him 2 days ago laughing with his brother when they were playing catch together or whatever it is, so that they've got something to compare to. Because it can be really tricky when you're meeting a child like Christopher for the first time who's just lying in bed. He's not going to talk to you. He's not going to engage with you. It's not like he can try and get up or roll over or any of those things. So it's really tricky for them to understand where he's at. So having a video of what he was like 2 days ago is a really great way for them to compare.
I love that tip of having that video because it gives them, here's what he was 2 days ago, and then this is the child that you're seeing today. That's a great
Yeah.
contrast.
It's a nice
There,
timeline for them as well.
yeah, exactly, and especially if there has been a change rather quickly, it
Mm.
gives that timeline, which is fantastic. Nerida, do you have anything to add to that?
Yeah, yeah, I do. And also, my daughter is, mostly nonverbal as well. And I think for them to understand, levels of pain, are actually a really tricky thing for the doctors to understand. And that's where, our baseline is. My daughter has a high threshold for pain. And so if she is actually, experiencing and being out of sorts as well, Maddie too is a really social butterfly. That also determining whether or not her being upset is because of pain, or it's because we're in hospital and she knows what's going to happen when you're in hospital. And so understanding the level of pain. I'll share with you, on our last trip to emergency, a new doctor, never seen us before, said, "Do you think she needs some endone for the pain?" And I said, "Endone? I feel like that's a little dramatic. I've never given her anything more than Panadol or Nurofen." But this person made some presumptions around her, the noises that she was making. And I said, "I don't think she's in that level of pain." Because she was in that level of pain, she'd actually be crying. She's not crying. This is just her way of going, "I'm really uncomfortable with this situation, and I've got a bit of pain, but I'm more unhappy about being in hospital and what that means, and I'm about to be jabbed with a few needles, as opposed to I'm in so much pain, I need a serious, pain relief." So I just said, "I appreciate your concern, but I don't believe that she's in that level of pain that warrants that level of pain relief." So I said, "Let's start with our usual. And then if I feel like she's in greater pain, then we can certainly move to that. But I don't believe we are." So, yeah, yeah.
Yeah, it really is important to re-educate our medical staff about what assumptions you do make, and especially when it comes to our kids. I know Lockie broke his leg a few months ago, and when we were wheeled in, it's kind of like, "Oh, well, is this a normal level of pain?" And I'm like, "Well, no. Like last time he broke his leg, he walked on it for 3 days." So it's making that, making that broader picture of like, no, the fact that he's not even willing to try and get up, that's a real issue for him. And
Mm.
I know even after surgery, like the irritability, and he will tell everybody off. It's really that gauging that of like, this isn't normal behavior for him. This is showing us that there is something else going on here. So really looking at that well-being versus pain
Mm.
as well. Where are we sitting in the continuum of things?
Exactly, exactly.
All right. Well, let's move on to pre-admission process. So I know sometimes surgeries can get delayed or bumped. What advice, Nerida, would you maybe give for families managing those situations?
You mean in relation to where your child
Oh,
is on the list? You
yes,
sort of,
where they're on
yeah,
the list, and then
yeah.
and yeah.
Yeah, so our kids, obviously, with having an intellectual disability as well, makes it very hard for them to understand why they have to fast, for example. And so I am constantly having conversations with the relevant people. Now, I'll come back to relevant people because that's the really critical part here. Relevant people around what is the process of determining the list. Obviously, we all know that emergencies and little babies have to be always first on the list. We appreciate that. But just because my child is 17, and that's all an anaesthetist will see, they'll see her paperwork and they'll see she's 18, 17. They won't see that she has an intellectual disability and other disabilities. It'll just say 17. I have asked the hospital if they could change the form to include this, but we won't go there. Let's just say the form hasn't changed. But I sort of, the thing is that they have to, because once you're in hospital and the anaesthetist comes around, too late. They've already determined the list before you even get in there. So I recently, as in last year, came across somebody at Ranwick who does actually have help with pre-admissions. And so I had a long chat with this person and explained to them around my concerns about every time we have a GA. It's incredibly stressful anyway, but it's always stressful because there's always these multiple issues that happen, and explain that Maddie can't be last on the list just because she's 17. Appreciate, as I said, babies and emergencies have to be first. So having a conversation with the right people, so finding that right person is the critical thing. I don't know what department this lady sits in at Sydney Kids at Randwick. Her name's Geraldine. I've got her mobile phone number and her email. So yes, I have to talk to her tomorrow, actually, Friday, actually, because we've got to go through this process for 3 GAs that are coming up over the next couple of months. So that is my advice, is to explain exactly why your child can't be last on the list. And just consider that, on this piece of paper, that's all they're going to see. All they're going to see is that your child is 17 and what they're coming in to have done. So it could be just a child with no disabilities whatsoever coming in who's 17. They're just going to be put last on the list because the older kids get last on the list. That's just the way the anaesthetists work. Yeah.
Yeah. No, finding those people who are in your court sort of thing that can back you up and help you navigate the system is really important. I think in my research for this, I found Westmead call it Kids GPS, so they actually look after their complex care, and there is a handbook available. And Steve Lewis has actually said how wonderful Geraldine has been, great for their care as well. So I will put a link into that hospital handbook as well to help out those people who might be involved in the hospital system. Pam, I was also wondering, for you and for Christopher, what are some other things that parents might do to feel more prepared for a hospital admission?
Just an admission in general.
Yeah.
So for Christopher, not too much. I always try and make sure that I've got some familiar things from home for him, like his favorite cuddly and a blanket from home, so that the environment that he's in can feel a little bit more like his own. We've always got to make sure that he's got all of his bits and bobs in terms of positioning and all of that kind of stuff. But for me, our hospital bag actually has more stuff for me in it than it does for him. It's got his pajamas and it's got a change of clothes and his cuddlies, and like all of his meds go with us and all of that sort of stuff. But our hospital bag for me, I always take my own pajamas because I feel better if I've changed into my pajamas to sleep and then change back into clothes in the morning after a shower with 64 of the shitty tiny hospital towels. And like taking things like our own shampoo, conditioner and soap, because that's not provided. I have a little container of my favorite tea bags, so that I can make myself a cup of tea in the parent room wherever we end up. I have like coloring or a puzzle book or a novel, like a trashy novel that you don't have to think about, just that you can completely escape your reality for a moment when you're not talking and advocating for your child. So just like lots of little creature comforts for yourself and your child that's going to try and help make everything a little bit more comfortable. In terms of like for us, Christopher's on 12 different medications. So getting all of those up and running through the hospital pharmacy is a mammoth task that often takes 24 to 48 hours. And even then they don't carry everything. So we just take everything. And it's often a fight to allow us to keep it in the room with us because some of his meds are in a certain classification, which means they're not allowed to stay in the room. But I have had this fight and this conversation with our hospital and medical team over and over and over again. We have notes all over our file that say we are allowed to keep his medication and administer all medication. We do it 4 times a day, unsupervised at home. And I think it is ridiculous that we have to make him wait for time-sensitive medication for when 2 nurses are available to be able to sign off so that I can give him medication that I give him unsupervised at home. So it's all about, like Nerida said, finding the right people that are going to stand in your corner and help you advocate for the best care for your child. So yeah, we take all of those things with us so that we can do it all ourselves, because it's one less thing that the nursing staff is having to worry about. They obviously do all of the IV and all of the prescribed medication that he might be needing while he's on the ward. But anything that we would ordinarily be giving him at home, we are in charge of.
Yeah, and I think that's such a valid point, that at home you are almost the medical professional in the room. You are the one administering those medications several times a day. And so being able to have that conversation with your hospital provider is so important that, you know, why does he have to wait when this needs to be given right here and now? And if
And
the option is for you to do it, yeah.
and a lot of us, a lot of our families would be exactly the same. Their meds are time sensitive. Like Christopher's on 4 different seizure medications. You can't mess around with those timelines because having seizures is just going to prolong his recovery and just complicate everything. So
Mm,
if we can stay on top of that and make sure that that stays at his baseline while they focus on getting him well for whatever it is that we're in there for, then we're good. It does actually mean, like, back to the pain thing, we often actually need to ask for pain medication for him because it's like all over it that we're looking after all of his medications. I don't take pain medication with me because they like to be on top of all of that. That's the only thing we don't take with us. So I often have to ask for his pain medication. We're the opposite to Nerida because he hides it really, really well. And just gets sleepy. And we learnt a very, very long time ago not to chase pain with him. We stay ahead of it. So I'd rather preemptively give him things to help him stay comfortable and aid his recovery than to try then let him get to a point where he's visibly uncomfortable and have to try and chase it. So yeah, but that's like every family has their own way of dealing with things, and we all just have to advocate for our kids and what works best for our kids.
mm,
Yeah.
That's
yeah.
I'll just add something there as well. We have the same arguments every time
Yeah.
regarding our meds. And I was told it's not really about the fact that they don't trust us, because that's how it makes us feel when
Yeah,
they
it
won't let
does.
us keep it. It's more about if somebody breaks into the room or if another kid walks into the room and grabs the meds. And, I just explain that, at the end of the day, um, they they're not left out in sight for that reason. Do you know what I mean? And
Mm,
again, time sensitive. We've had these issues before. I'm not going to go through this again, those sorts of scenarios.
yeah.
The other thing when you're packing a bag, for example, and touching on Pam, what you said about it takes the pharmacy probably 48 hours to get up to speed with what
Mm,
your meds are. Sometimes they won't even have your meds.
yeah,
So
yeah.
we take
Mm,
all of our meds as well. And the other thing that I take now, because it's really hard, Maddie can't swallow a tablet, so everything has to be in liquid form. And I've become quite the chemist. Um, and every time a new drug is prescribed, I ask what formats these come in because we can't do a tablet. Is it a capsule that will open? Because then I can put it in something. Is it a
Mhm.
liquid cap? Because that's even better because you end up with maybe just 3 mils or not even three, well, less than a mil of medication that would normally be 20 mils. So one of the things that I take with me now is liquid capsule Panadol because I only found out last August. So we've been doing this gig for 17 years now. No one's ever told me that you could have IV Panadol. No one. The
See, that's
reason,
crazy to me.
see,
We've been using IV
but
Panadol for forever.
I was told, so a nurse told me that it's really expensive and there's not a lot of it in the kids' hospital, which is why they don't offer it to everybody. And I
Mm,
said, so, okay, so do you have the liquid caps? No, we don't. Okay, so I'll bring those in. So I take in anything that I know so I take in Nurofen caps and liquid and Panadol liquid caps. Um, so that, because they don't have those, they only have
mm,
the kids' version of Nurofen, which still for our bigger kids is like 20
yeah,
mils on top of everything else
so
she's got.
much.
Yeah. So, yeah, I just, just be mindful that yes, they're a hospital and yes, there's a pharmacy there, but they're not always going to have the
yeah,
meds.
they don't always carry what you
Yeah.
need. There's 2 of Christopher's medications that aren't carried by the hospital pharmacy and they can't get it in.
Yeah.
So
Yeah.
even if they get their heads around the other 10 that he needs, I still need to provide 2. So we just do all
Yeah.
of it. Yeah.
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 And on the topic of medication, so quite often when we'll have a surgery planned, um, I know, Nerida, we've spoken about having that conversation with the anaesthetist about, what are those pre-medications that need to be given, and then going into recovery, what needs to be done. Could you elaborate a little bit on what your plan usually is with Maddie?
Yeah, sure. So obviously the first plan is that we need to be close to the beginning of the list as possible. There needs to be a hoist in when we arrive, and preferably a hoist with for loops, a sling with loops, not that stupid clip one that they use in the hospital. Um, and then we need to have a conversation pre about anesthesia. So because she's hard to cannulate and she doesn't like a mask because it's just too scary for her, she needs to have a pre-med. So we talk about a pre-med. Again, we're keeping volumes down, so I asked for it not to be watered down or put in juice because then that will take me an hour to get this much into her. Whereas cold turkey, I know it sounds horrible, but cold turkey, it's one squirt in her mouth and we're done for a pre-med. Obviously, it makes sense, but it doesn't always happen that if you're having a pre-med, you've got to wait for the pre-med to work. So no good just throwing the pre-med in the mouth and then wheeling us into theatre. We need time for that pre-med to work. That's the whole point of having a pre-med. So, there has to be a 20-minute period between having the pre-med and going into theatre. And then obviously understanding that my child normally takes a long time to wake from an anesthetic and you've just given her a pre-med, so that will take her longer. So understanding that obviously if she's at risk and you need to give her a reversal drug because she's not waking, I understand that. But if she's not at risk, can we please just let her sleep? Can we please just let her wake of her own accord when we're in recovery? So that's really hard for hospitals because they want to get us in and they want to get us out because they need to get another patient in and another patient out. But sometimes you can be on a winner. And Geraldine, I don't know what she does, but she was just magical for our last um, planned GA that we got. Somebody in recovery that actually said, I actually prefer to just let the kids wake of their own accord. So I went, that's fantastic that you're speaking my language. And then things like having a conversation about the cannula. So obviously they prefer to leave the cannula until you move from recovery up into the ward. But for me, for Maddie, as soon as she's awake, that will cause issues for her and she will not be able to settle. And so then they'll think that she is in pain. She's not in pain. She's just upset that she's got this cannula in her. And again, if she's not at risk, let's take it out. If she's already had something to drink and she's already eating, can we take it out even though we're not back at the ward? If you think she's at risk, okay, I will try my very best to try and, placate her and distract her and all of those sorts of things. But, she seems fine to me. If you think she seems fine, then can we just take it out? So it's just having conversations about that with confidence and not in an ordering fashion, but just saying, this is what works for my child. This is what we do each time, um, and just, I guess, saying, I appreciate that if she's at risk, you need to do this process because that's they have to do that from a risk perspective. But, it's just, this is what works for my child. So,
I think even going back to that well-being idea, I remember a few years ago with Lockie, he'd had a bit of a traumatic experience. They decided to wheel him in. He wasn't having that, so they decided to do the pre-med. And I was trying to calm him down, so I put on a calm story. It was actually a sleep story on the Calm app, and this nurse was determined I had to turn off the iPad because that's too stimulating for him. And I'm like, but it's a sleep story. The whole point is to try and get him to relax. So I think, yes, standing by, what you believe in, what you know your child to react to. is so important as parents. And at the end of the day, they don't know your child. They see many children go through their operating suites every day, but you're the expert in your child. All right. So talking about advocacy, um, I was wondering, Nerida, can you share an example of a time when your instincts have told you that something wasn't quite right?
Yes, I can. I have a few, but I'll tell you the best one that I think's the best one. So Maddie went in to have orthopedic surgery, and I'm sure everybody on this call knows that when you go into hospital, whoever is you're admitting, whoever you're going in is, the head of the hierarchy tree while you're in hospital. So because we were being admitted under orthopedics, I already had organised with all of her other specialists, and the critical ones are hematology and neurology because she also has epilepsy, was that in the event that things happen or go awry, what will be the plan? Because this surgery was at the beginning of January, and as most people in here on this call would know, most specialists are on holidays in January. Most of the hospital is on holidays in January. So I want to have backup plans in the event that something didn't go to plan. And so you may recall at the beginning I said there's a temperature protocol with my daughter. So she's had the operation, and it's the next day, and she spikes a temp. And I said that as she spiked a temp, we hematology now click in, right? Our protocol clicks in. And I actually think she's got pneumonia. So, because she's had pneumonia multiple times. And so orthopedics come and assess her and say, look, it's normal for a child to have, sort of what seems like a chest infection post and to get a temperature post surgery because the tube's going down, you're filling up their lungs, all those sorts of things. And I said, I understand that, but have you done this surgery on a child with a blood disease before? No, you haven't. And have you read what the plan is in the event that she gets a temp? No. I said, okay, so here it is. Here's the email, and you are CC'd in on this email. And in the event of a temp that, hematology has to, the protocol has to. So can we call hematology now, please? And can we also organize a chest x-ray? I can guarantee you, Nerida, she doesn't have a chest infection. I said, I can guarantee you she has a chest infection. So hematology came, said, yes, Nerida, you're correct. We have to get her on other antibiotics now because of that hierarchy. Orthopedics are in charge when you're in there, regardless of who else is on your team. Orthopedics are in charge. So they have this level of respect. I'm going to put respect, but sometimes it's just you have to force people to talk to each other within the hospital to ensure that your child gets the best care. So we ended up getting the antibiotics that she needed. We ended up getting a chest X-ray, and guess what? She had pneumonia.
Infection. Mhm.
So there, yeah. So I guess there's not much more I can say except just stand your ground, have a
Yeah.
plan in place. If it warrants having a plan in place before you even go in to have some sort of surgery or some sort of and just know how the hospital works and how orthopedics were not going to call hematology. They weren't because they're in charge. And so you've also got to have that conversation with them to make sure that they talk to each other and they listen to each other as well as listening to you. So I appreciate that can be hard. But once again, I always say, I always just say, look, I'm not being disrespectful of your knowledge, your medical knowledge, but I am the expert in my child and I know what pneumonia looks like in my child, and this is pneumonia. So I don't need an x-ray, and I didn't. So
Yeah. I think like a lot of the time it comes down to like we need to trust our guts because we do know our kids better than anybody. and we're more likely to pick up if something is wrong than anyone else. But like, I think communicating the fact that you feel uncomfortable with what's going on, like there's something's not right. I don't have that comfortable feeling right now that things are going the way that they should. And I don't feel like my child is safe. Like, you're allowed to say those things. Like, you're not being disrespectful. You're not bucking the, trying to rock the boat. Ultimately, your gut is telling you that there's something wrong. So you don't need to worry about hurting people's feelings or tiptoeing around who's in charge. Like, you need to get your child the help that they need. So we've had a similar situation. So a little bit unique. We are in Canberra, and there's no major pediatric hub here in Canberra. So we get a lot of care and treatment and specialties at Sydney Kids. So my son Christopher had surgery on his hips at Sydney Kids. We were discharged 5 days later. We came home, and in a rare turn of events for him, I had managed to wean him off the pain meds after just 2 weeks, which is very rare for him. Normally he's on them for weeks on end. But he was doing really, really well, and we were stoked with his recovery. Even him within himself, he was happy, he was doing great. And then suddenly he started crying just all the time. He was miserable. He was telling me there was something going on. And I said to my husband, I was like, there's something wrong. I can't put my finger on it. The pain meds aren't helping. There's something else going on. I think it's connected to the surgery, but it's not directly related to. There's something else happening. So we took him up to emergency here in Canberra. And as the majority of emergency departments are, they were overworked and understaffed, and it was absolute chaos. I remember sitting in the bed with Christopher, getting really upset, being really, really uncomfortable because the guy next to me was from jail, and there were like security guards and like prison guards outside his curtain. It was just the most bizarre experience. So I can appreciate how stressed and overwhelmed the staff were. But they essentially assessed him and said, we can't see anything really wrong. He's probably just in pain from recovering from the surgery. We recommend you double his pain meds. Take him home, make him as comfortable as you can. I was not okay with this. The pain meds we're on are not for the faint of heart. It's not just Panadol and Nurofen. We're on pretty heavy stuff. They knock him out usually. And I didn't want to just knock him out and mask whatever was going on. I wanted to get to the bottom of it. So I spoke to our physio here in town, and she, by some miracle, was able to come and see me that afternoon. She came and assessed him, and she rang the orthopedic section in Sydney, where he had the surgery. And they said, if she can get him here tomorrow, we've got space in clinic tomorrow. So we chucked him in the car, got him up to Sydney. As soon as we arrived at the clinic, they took his cast off. He had severe pressure sores on his knees that took 4.5 months to heal. He still has scars from. And if I had followed the advice of the doctors at emergency, the pressure sore infection would have gone into his blood and he wouldn't have survived. I did not accept that doubling his pain meds was an acceptable course of action and that was going to fix the problem, because my gut told me that was wrong. So keep asking for people to fight for your kids, keep advocating for them, keep kicking up a stink and making noise until someone listens and you get your problem fixed. Because like Nerida, I knew there was something going on and my kid needed help that I wasn't able to provide. So I had to find the right person that was able to help us with that. So we're so incredibly grateful. Like, I call my husband all the time. I'm like, something's not great. I don't know whether I should take him to the hospital. And he goes, your gut's not wrong yet. Okay, yep, fair. Point taken. We're going to hospital. No one wants to go to hospital, but sometimes you just need someone to reiterate, we know our kids best, and that
Mm.
knowledge is so empowering, and we need to just, like, forget egos, forget who we're trying to impress. We need to be safe and comfortable in the knowledge that our kid is okay. So,
There really is
yeah.
something to be said for that parental instinct. And I think when you are a parent of a child with a disability, you're not just showing up to the ER for the sake of it. You're just showing up when you know that there is a serious issue and something that needs to be looked into or taken care of, or, you know, whether it is a cast that needs to come off or something like that. You know the signs to look for. You've been
Yeah.
doing it for such a long time. And it really is having that faith in yourself and in that gut instinct to know that, yeah, the time has come and I need to head to emergency.
Yes. Because
Yeah.
no one's their best self when they rock up at the hospital, and no one wants to be there. It's not like an amusement park where you go for a fun roller coaster ride. It's not a fun roller coaster ride. It's malfunctioning, and I wanna get off,
Mm.
um, at all times. No one wants to be there, but sometimes in order to keep our kids safe, we have to go there. Um, and it shouldn't be up to us to fight as hard as sometimes we need to for them to get the care that they need. Yeah.
No, completely agree. And we do know our child's best. And we're problem solvers. We have to be problem solvers in this role that we've been given. So again, if we're problem solving and it's still not working, that's when we know there's a time to step it up a notch and go find some answers. Well, I want to extend my sincere thanks to both Nerida and Pam for sharing their valuable insights and expertise with us today. I know I've come away with many new ideas of how to tackle our next hospital visit, be it an emergency or a planned admission for surgery. And thank you to all our participants for your attention today. Your engagement in the chat has made this session even more valuable for everyone. But in the coming days, all registered participants will receive an email containing a link to today's session. Any additional resources that was mentioned in the presentation, I'll put in that handbook from Westmead Kids as well, and ways to connect with alongside families and continue the conversation. And we do encourage you to stay connected with us. So um, I know Pam mentioned this on Monday in the medical webinar, but we do have an exciting brand new Facebook page just for families of a child with a disability and high medical needs. So this is a supportive space where parents can connect with others who truly understand the journey, share tips and advice about navigating hospital stays and the healthcare system, and find encouragement on those harder days and celebrate the wins together. Now, if this is something you would like to join, I will put the form in the chat and you can access it. Well, I was going to, but now my screen has decided to do crazy things. You can access it. It will also be sent out in the resource email so that you can join through the resource email as well. I've put that in there for you now. And remember, you can also join us on Facebook, Instagram at Alongside Families, as well as subscribing to our newsletter for regular updates. Before you go, I'd like to highlight our next medical webinar, which is on paediatric palliative care. It will be our last medical webinar for this term, and it will be with Pam on Monday, the 22nd at 12 p.m. And I'll also put the link for that in our chat. Now, often sometimes people think about palliative care as an end of life service that's only offered then, but it's actually more about empowering those families with serious medical conditions on their journey in a really family centered way. So we hope that you can enjoy or join us for that webinar. And remember, you can always check out all of our events at www.alongsidefamilies.org.au. I will also bring your attention to the webinar that we had on Monday was with the Clinical Excellence Commission. And if you haven't watched that, it really is a must see. We today we've looked at the parent point of view about making your voice heard, but Monday's session was all about what is in place from a hospital point of view. So we looked at REACH and when we can actually access the REACH program. And we also discussed the new policies that have been brought in where you will be asked, are you worried about your child? Are you worried that they're getting worse? And that will be done at every OBS check-in that is taken. And it's a really good way to just arm yourself with that information so that you are prepared for that next medical appointment or hospital stay, and you know that that will be coming. All right. So once again, thank you for joining us today. Thank you, Pam. And thank you, Nerida. And we will look forward to seeing all our participants at future Alongside events. And I hope you all have a wonderful day. Thank you, everyone.
Thanks, Kelly. Bye.
Thanks, Kelly. Bye. Bye,
Bye.
everyone.